Therapy Chat Podcast, episode 256.
This is the Therapy Chat Podcast with Laura Reagan, LCSWC. The information shared in this podcast is not a substitute for seeking help from a licensed mental health professional. And now, here's your host, Laura Reagan, LCSWC.
Today's episode is sponsored by Therapy Notes. Between writing notes, filing insurance claims, and scheduling with clients, it can be hard to stay organized. That's why I recommend Therapy Notes. Their easy-to-use platform lets you manage your practice securely and efficiently. Visit therapynotes.com to get 2 free months of Therapy Notes today. Just use the promo code TherapyChat when you sign up for a free trial at therapynotes.com. Hi, welcome back to Therapy Chat. This week, we are again going to be talking with Janet Courtney, PhD, who is an expert in infant and child and family therapy with children and families that are affected by trauma. This week's episode is part 2. My first conversation with Janet we heard last week, and if you missed it, there's a link in the show notes for this week's episode. This week, I think the topic is something that I have heard less about and definitely did not learn anything about in school, which is infant mental health. So I think that this will be really interesting to you, whether you are just someone who's interested in understanding more about mental health, or if you are a clinician or a parent. We were all once children, and this information is relevant to all of us. So I hope you'll enjoy our conversation. Let's dive right in. Quick note, I just wanted to make sure you know that if you are a therapist who's interested in joining one of my trauma therapist consultation groups, I will be opening up registration in January, and more information will be available here starting in January 2021. All the information you'll need to register. Thanks. And I'm really glad that you started talking about the kinesthetic storytelling. I'd love to sort of shift gears a little bit and talk more about your work with 0 to 3 children in that age group and your first play therapy method. And because, as I was saying to you before we started recording, I just don't think that there is a lot out there about ways to work with infants and toddlers who have mental health challenges that they're faced with. And in our culture, we tend to just think they don't know what's going on. They don't remember, so they're not impacted when something traumatic happens.
Well, absolutely. And this is one of my areas of expertise is the infant mental health and infant play therapy modalities. And I also just had a book that came out in April of this year called Infant Play Therapy, Foundations, Models, Programs, and Practice. And I also have a chapter on infant play therapy in the Healing Child and Family Trauma book. But you're right that what we know about working with children, especially in the area of play therapy, is a lot of the focus over the years. Traditionally, we've worked with children and been trained to work with children ages 3 to 4 and above, which left a huge gap of, okay, so what about the 0 to 3 populations? And a lot of what we know now is that there was always this myth that because maybe a young child didn't recall or remember a trauma that they might have had as an infant, then since they didn't remember it, then they're okay. Well, we do know now, and I credit the amazing neuroscientists out there, what I call all the really smart people, Bruce Perry, Daniel Siegel, Van der Kolk, Alan Shore, all these really amazing people who now research, the neuroscience has come to the forefront in the past, like say 20, 30 years, to really let us know that peering into the window, of the mind and the brain, that yes, that brain really is wiring up in those early years. And the neurons, the synapses are firing, and they're experience dependent. So if they, it's like the neurons that fire together, wire together, and those that don't die together. And so going back to that, it's experience dependent.
Can you explain that phrase, experience dependent, just to make sure everybody's with you?
Right. So it's relational. It's what that infant has gone through, their life experiences, what has been given to them and what hasn't been given to them during those for that first year of life, the second year of life. And so because the brain is just amazingly just growing. It's coming together. It's, as Alan Shore explains, it is wiring, and then then it dies, and then it kind of comes back, and it's based upon what life experiences that the children and infants are experiencing during that time. So who are the caregivers in that child's life, and what type of caregiving are they receiving? So that we have attuned caregivers? Do we have, as that child has caregivers that attend to the needs? I was able to spend time, my husband and I, with the Bowlbys a few years back, Sir Richard Bowlby. And we were invited to their home in England, which I was very, very honored about that. And so, but Richard talks about, and he's the son of John Bowlby, and he always talks about this, he asks this question to his audience. And of course, I've learned it from him, and I provide it in my trainings to the practitioners that I'm training. But he says, what are the two most important things that help to build a secure attachment relationship between that parent and the infant? So think about that for yourself, Laura. I'm going to ask you that question. Mm-hmm. What are the two factors that help to build a secure attachment relationship for an infant? I'll put you on the spot a little bit. And we'll ask the listeners to think too.
I mean, I don't know what the answer should be, but I'm going to guess that attunement would be one of the main factors, and the presence of a secure caregiver, a safe, secure presence of the caregiver. Those are the two things that I come up with.
Mm-hmm. And, and it's like, yes, absolutely. And so the way that I've learned it is, the first one is how sensitive that parent is in helping to relieve the distress of that child. So if the child is in distress, how sensitive is that parent to help to lower the stress in the child? So what is the distress? The distress would be, are they hungry? Are they cold? Are they afraid? Are they sick? So these are some of the areas that we look for. What do we mean by distress? Not, did the parent take the cookie away from the child or say, no, you can't have that cookie now. That's a different type of distress.
Yeah.
So, but that is the first one. And the other one is, and this is where, when I heard this, I fell over in my chair, because I was like, are you kidding me? This helps to build a secure attachment. But when you think about it, it's really the truth. And that is, how much does the parent or the caregiver and the child experience joy within the relationship? So it's the joy within the relationship helps to build secure attachment relationships. And so that's really, for me, the crux of what the work is, in a foundational work in the first play therapy, where we're helping to facilitate joyful experiences between that parent and infant, or maybe that parent and the child. So we're focusing on the strengths in the relationship. We're focusing on the resiliency in the relationship. But going back to the joy, if you think for yourself, and if you have relationships in, your life, a partner, what made you decide that, maybe you had a date together, but what made you decide that you wanted to have a second date with that person? So, or if you have a group of, friends, girlfriends or, guy friends that get together and you go out for lunch together, which I can't wait to do, by the way, after all this COVID's over.
See friends.
Yes, absolutely. But when you're done with that lunch, what do you usually say? Let's say you're out with a group of girlfriends. And what do you say? Say, let's do this again.
Mm-hmm.
Let's get together again. When can we do this again? Well, that all goes back to that parent-infant relationship, and what we call the reciprocal serve and return of the relationship is where, the parent initiates something to the child, and then the child might coo back to the parent, or they smile back to the parent, or they use that wonderful body language to say, yes, I love this, do this again. That they are doing every single signaling to that parent that I enjoy this, I really, really like this, let's do this again. And so it's a reciprocal, co-regulated relationship that then begins to happen. It's a beautiful, beautiful relationship. So in my first infant play therapy model, what we're doing is to help to facilitate the joy within the relationship. And how do we do it? We do it through teaching parents how to provide touch techniques to their infant. At the same time, they're also learning a therapeutic story, and it's a manualized program. So the story is called The Baby Tree Hug. So we pretend that the baby's a beautiful tree. And so we teach the parent how to guide them to touch the legs, the limbs of the legs or the limbs, and the feet or the roots, and the hands or the leaves. And so then we're encouraging the eye contact, that's happening between that parent and child, and also being attuned to how that child is responding to the touch. So we teach the parent prior to beginning the story massage how to ask permission from their infant, how to respect them. And that begins in infancy, and then we take that all the way up through childhood, always respecting that child, and that the child recognizes, I have boundaries. I have boundaries that need to be respected. And so I have one of my practitioners told me that she had a grandparents that had custody of their grandchild, and the child was like about 2 years old. And so she did the first play therapy model with the grandparents. And so the parents taught the child, the baby, or she's 2, that we have to ask permission first. And so the practitioner came back and the grandfather said, well, you've ruined it for me. Now she's asking me that I have to ask permission for everything. But he said it in a way that was, I'm happy about this because I'm feeling good that she knows that she's developing boundaries, and that she has boundaries, and that she has that her body belongs to her. And that so many family systems where that's not taught, and the boundaries of body are so violently, violated.
Yeah.
And so it's huge, huge work that I feel like I'm bringing to the table here, because, we crave touch, we need touch, but how do we give it? And that also reminds me, I have a friend, and she's in England, and her name is Jean Barlow, wonderful woman. I love her to death. But she has a program called Child-to-Child Massage in the schools. And she's actually taken it all over the world. But they actually teach the children, but they start them in like preschool, how to provide touch to children in the classroom, but they do it through like massage on the back. And children always have to ask permission of each other before they can, have that time. And so I have a girlfriend who's a school counselor, and she says, Janet, it's so beautiful and she's in the UK. And she said, so beautiful to go, after lunch, they usually do the period massage in the classrooms. And she'll go, and I'll walk by the classrooms, and I see the room lights are dimmed, and the children, they have some light music going on, and the children are providing this time to each other. So I use that model as a foundation for the kinesthetic storytelling, for one of the roots of what I use for the kinesthetic storytelling. But it's pretty amazing what they're doing in Europe and in different places with the children in the classroom. And I have another book that I'll mention here. It's called Touch in Child Counseling and Play Therapy, an ethical and clinical guide. And that there is a chapter in the book that's related to that school program that I just mentioned and I just talked about.
Yes. And that, for all of you who are internally recoiling at the idea of touch in therapy, even though this isn't about the therapist doing the touching, it sounds like that book would be able to help everybody settle down and understand a little better how it can help.
Right. Yeah. Thank you. Yeah. It's a powerful book, and, it looks at touch from all different angles for, children that have been sexually abused, and, therapeutic models that use touch as an intervention, which mine, for the kinesthetic storytelling, it is a therapeutic touch model, but again, we're not providing that. We're using the parents as doing that, but it is a sensitive topic. And again, I write about that touch, the area of touch, and the Heal a Child and Family Trauma book as well.
That's wonderful. And, when you were talking about the baby as a tree, I forgot exactly what you called it, but that intervention that the parent can do with the child, I just had this thought that the first thought was a sense of delight, like the parent and the child are experiencing delight within their relationship together.
Oh, that's such a beautiful word. I love that word. And that's exactly what we're facilitating, because we know when we provide that touch and we get the hormones are being released in the body, those positive hormones, the serotonin, the dopamine, the oxytocin, that those high levels of joy are, I know in that moment, the child's brain is wiring up for healthy neural pathways.
Yeah.
Yes.
Let's just pause for a moment so I can give you a little bit more information about why I love therapy notes. I switched to therapy notes a few years ago. I'd say it's about 3 years now, I believe. And I have never regretted it. I was very happy with the EHR I used before, but therapy notes is more intuitive. I love the interface. The customer service is fantastic. And I love how I can get my notes done quickly because I can customize the template that I use for my notes, and there are opportunities to put check marks rather than having to write out the intervention used. So I have cut my time spent writing notes way down, which is wonderful because I like to focus on seeing clients. I know documentation is an important part of our work, but it can also be time consuming, and that is why I love using therapy notes. If you are considering switching EHRs or you're looking for one to use in your practice, give therapy notes a try. You can get 2 free months by using the code TherapyChat. Now let's get back to our interview. Exactly. And you know how, I know most of us probably have heard before about the studies where the infants and young children who were so severely neglected in orphanages in countries like Romania, and they did the brain scans and found that the areas of the brain that experience joy and pleasure were smaller. I hope I'm remembering that accurately. So if you know that I'm missing it, please tell me. But just thinking about how, like, you want to be able to have the experience of joy as one of those neural pathways that's like the superhighway, not the little dirt road,
That's a good way to put it. But yes, I mean, that's a very sad thing that we understand that happened in some of those orphanages. And yes, I'm aware of those brain scans, and in the areas of the social and emotional development in the brain that they absolutely were like black, blank. There's no activity happening within that part of the brain. But and it's not easy, but it can be done. So what I want to bring here is some hope. And this goes back to the mentor that I worked with, and she got me all on this touch topic because she wrote a book called The Dialogue of Touch. And when I first met her back in the early 90s, I attended a workshop with her, and she was talking about a play therapy model that worked with children not using toys, but using the relationship. And back then, with developmental play therapy, which was her model, the practitioner would do the developmental games with the children directly. And as I was sitting in this workshop, I raised my hand and I said, Dr. Brody, I said, what about the concerns of practitioners touching children? And of course, she had been, she was in her 80s at this time. So back in the day, the concerns about practitioners touching children or teachers, it wasn't so highlighted for us until like around the 1980s when all those high profile cases came into being. And then everybody as a society went, oh, what? You mean, we put these people in trusted positions. But anyway, so her response back then was like, oh, I've never had a problem with it. And so I have to say, you always have to be careful what you ask, because I actually ended up answering that question. And what I realized later is like, oh, it's the ethics. It's the ethics of touch. So going back to those children, in Romania or orphanages is the lack of touch. And that we know that touch and attachment go hand in hand, literally. You can't talk about with touch without talking about attachment, and attachment without talking about touch. They absolutely go hand in hand together. And this goes back to the sadness that we're aware of, is that some infants are, abused, and some infants don't get the experience of someone giving them nurturing, loving touch. But the hope is, and this is where I want to come back to, and I know I'm coming full circle now, that the hope is, and this is what Viola Brody would say, is that for, especially the younger you can get to them, the better. If a child did not get good experiences in those early years, that it's not too late. If we can have a good, caring caretaker, a foster parent, who can then be taught how to have that child pick up what they missed, teach them how to go back and give that child and I call it first play because it's the first type of play that we have in life, that luscious play between a parent and an infant, where there's that joy within the relationship. So if we can teach that parent or the caregiver how to give those experiences to that infant or to that child, they can actually pick up what they missed. And this goes back to the neuroplasticity of the brain. The brain can change. So I had a situation one time where I had a mom, she adopted a child from China. And so at 4 years old, and she got the child when the child was about 12 months to 18 months. I think the child was about 18 months old when she finally was able to bring the baby home. And so then she came to me, and the child was now 4 years old and was having night terrors and, a lot of behavioral problems. And so I said to the mom, I said, well, when you brought her home, I said, how did you interact with her? What did you do with her? And she goes, well, I just treated her like a regular 18-month-old child.
Mm-hmm.
And I said, well, did you sing to her? Did you rock her? Did you play, developmental games like peekaboo? And she looked at me and she said, no. And then I explained to her a little bit of the theory and how, children can pick up, what they miss. And, if they miss those developmental experiences, that, what can happen. And then I looked at her and I said, well, guess what? And she said, what? And I said, it's not too late. And then she looked at me though. She was really stunned, and her mouth just kind of dropped, and she said, you know what? I wish somebody had said this to me, had told this to me when I brought her home when she was 18 months old. So anyway, I gave the hope, and she was willing. That's the other thing, with when we're going to go back and do the work of the developmental trauma and do the healing work with it. You have to have the available caretaker that's willing to put in the work to do it. So that goes back to the commitment of, okay, I'm going to teach you these ways, and we can practice in the office together, and I can guide you. But then when you go home, you have to commit to at least, 15 minutes, 2 times a day, 15 minutes. And I say like 10 minutes, 15 minutes, and, just to make it like something reasonable. Because if they feel like, oh, I have to do the whole, story, massage with them, or if I have to, if it seems like a long time, then they say, oh, I don't have time to do it. If you say, oh, if you just do 5 minutes, if you do 1 minute, then hopefully when they start practicing and getting together, then it feels good and joyful, and then they'll continue. So I just offer it in bite sizes, but we need for them to make that commitment. So it's okay to ask our families to do that. I mean, they're coming to you, they're paying, their insurance is paying to see you, or they're paying out of pocket to see you, or however, you're being reimbursed. So we have to say, okay, it's not going to just happen, the magic, just with me here 1 hour a week or every other week. You have to also be a partner in this with me as a parent to, provide the interventions that I'm asking you to do, or, give it a good try. And if that one doesn't work, let's try another one.
As I hear you talking about that, I think about a question that, it may be a little off. I don't know. It's not quite off topic, but it's like, I think for many parents, well, let me just say this. I tend to work with families, if I'm working with a child, which I don't do now, but I have in the past, oftentimes where the attachment wounds are for the parent and where the parent's trauma comes into the relationship is where it interferes with the child and parent relationship, it seems. So when you said, the parent has to be willing, I'm wondering if you have any suggestions, guidance for therapists who are working with families in this way, where how the therapist can help the parent get bought in. Because, I think if they have their own trauma or their own attachment wounds, it can feel too vulnerable somehow.
Mm-hmm. Right. Well, that goes back to we have to start with the parents first. And so we have to understand especially when we're looking at the first play model, but we have to understand their touch experiences in life, and we need to understand their attachment experiences. And because again, this goes back to they can only give what they've received.
Yeah.
So if especially when we're in session together, and this is where we can lose out on, having to do things telehealth. I mean, there's limitations to the telehealth process. but we can do our best to work with parents in that way. So sometimes we need to have sessions that are separate from the child, because now we're working with the parent with their own inner wound of their inner child wounds that need to be addressed. And sometimes as a therapist working with children, we always have to kind of make the distinction of boundaries and where am I going to be the therapist for the child, and where might I need to refer this parent to someone like you, to maybe work on some of the areas that we've identified in the sessions. So I can, take it so far with them, but sometimes I would do that. I would have, say, you know what, maybe it would be good for you to see Laura and Laura can maybe kind of dig deeper with you with this. And then it kind of helps to keep that hat, for like, I'm the child's therapist. I could be the family play therapist. But now once we get into the, now am I going to be the couples therapist? You see what I mean?
Yeah.
And then it starts getting really, especially if they decide that maybe this couple is deciding they don't want to be together anymore. And then, oh my goodness. And then I call the child therapist, I'm the neutral in the relationship, but then, it can get very, very, very out of control very, very quickly. So I've learned over time, it's better to have different people that can, different therapists that we can refer to that can then handle the different areas that may emerge. But then again, on the other hand, if it's like a parent who has some wounds and maybe they were abused as a child, and so now I'm teaching them to provide touch with their child. So maybe again, this goes back to if I'm in session with them, I might say, can I show you on your arm that, what I mean by this type of movement, this type of touch with your infant? Is that okay with you if I do that? And so then I can touch them, if the parent is agreeable with that, and I can show them on their arm how to do that. Or if it's a backstory, I say, are you okay if I show you on your back and do this with you? So the parent can feel it, and then they feel it, then they know what that infant is experiencing, or they know what the child is experiencing. But then I might have exercises of connection that I might do with the parent. Like, in my training, I do like a holding hand exercise, have practitioners hold hand with each other, and one's the giver, one's the receiver. But that's really relevant. That's a powerful tool to use with a parent or a teenager. I've used it with teenagers in the office where, we just maybe hold hands for a few minutes before we start the session just to connect, depending on the presenting problem, depending on the issue because it might not be obviously relevant for all the children that we're working with. And then it's also the mediating factors. If that was a teenage boy, I might not feel comfortable doing with them versus maybe a teenage girl, I might feel comfortable, so we always have to look at all the different mediating factors involved in that type of touch. And then you have to use your clinical judgment for it.
Thank you. That's awesome. And we've been talking a long time, and I'm still eager to learn so much more. But for now, can you kind of finish up by telling our listeners a little bit more about your training program and where they can get more information about that and your books and anything else that you're doing?
Okay. Well, thank you so much. Well, I do have a website, and it's www.firstplaytherapy.com. And you can go there and learn a little bit more about the infant model, and then also the model for the older children. I have an online course for the First Play Kinesthetic storytelling course, and it is a self-paced course. It's intensive. It's like 35 hours of recorded training.
Wow.
And at the same time, because it leads to a certification. And then it's like 3 different levels. And once you go through level 1, then you contact me, and then we set up a supervision or a consultation time together. And then there's level 2, and then we have and then I have ongoing group sessions that I offer with that. And the First Play Infant Model program, I have normally always told myself that I would always be in person. And because of COVID, I just did my first group online in July. And I was so surprised how successful it was, because what happens is we have a live lab. And in that live lab, we actually have real parents and their infants come to the training. And in this case, the parents came on Zoom, and the practitioners that were going through the training, they learned the manual, and they implement that manual in real time with the parent and infant together. Well, I've never done this in any other way other than live trainings where the parent and infant actually come to the training. And it's to me, it's like party time. It's like I always get so excited when the babies come and the parents, and it's so magical. It's such a magical experience, and each practitioner is paired with their own parent-infant dyad. Well, again, I just did this online, and it worked out really well, and the parents gave very good feedback on how they said that, doing it virtually really worked out well for them. So the next training coming up is in November for the First Play Infant model. And again, that's going to be online. Now that training is 45 hours. And it's very intensive. And then beyond that, and that's for a certification, then there's some, they have to implement what they learned in real time beyond the training for the requirements for the certification.
Well, it sounds amazing. And is it a CEU training for the certification?
Yeah, I as a play therapist, I'm a provider through the Association for Play Therapy. Some people are, you have to have so many hours to become a registered play therapist or registered play therapy supervisor. So some people are working towards their hours, and they gain that in that way. And I also am a provider through the state of Florida for CEUs as well. But anyway, beyond that, the Healing Child and Family Trauma through Expressive and Play Therapies book, that is online. If you go to Norton Publishing, I know that they have a webpage there for the book. And then also it's on Amazon. And then my other two books are also on Amazon, the Infant Play Therapy book and the Touch and Child Counseling and Play Therapy book as well.
Fabulous. I am so grateful that you took the time to come and talk to us on Therapy Chat today. This was a really fascinating conversation, and I really enjoyed it. Janet, thank you so much.
Laura, thank you so much for the invitation, and you are a wonderful host. You really are. Thank you.
Today's episode is sponsored by Therapy Notes. There are many ways to keep your practice organized, but Therapy Notes is the best. Their easy-to-use, secure platform lets you not only do your billing, scheduling, and progress notes, but also create a client portal to share documents and request signatures. Plus, they offer amazing unlimited phone support, so when you have a question, you can get help fast. To get started with the practice management software trusted by over 60,000 professionals, go to therapynotes.com and start a free trial today. If you enter promo code TherapyChat, they will give you 2 months to try it out for free.
Thank you for listening to Therapy Chat with your host, Laura Reagan, LCSWC. For more information, please visit therapychatpodcast.com.